Sorry for the lecture drop. If you have missed out anything, the recording will be there on the YouTube, so we can continue there. And a new modality which has come. So let's continue. If anybody has left out, there are already, the video has been uploaded to the YouTube. The last lecture has the missed out portion, so you can go and collect it from there. So whenever there is going to be a spasticity in the patient, whenever that spasticity is not recovering at any cost, so they have introduced what is called as an intrathecal baclofen pump. So here you can see that whenever you are going to have a region, the baclofen pump is going to be introduced in the region of the spinal cord, and here you can actually inject whenever you need to require the injection of baclofen. So it is a catheter from wherein the baclofen can be injected at a periodic basis, and because of that, actually the muscle spasticity is going to be relieved. So continuous intrathecal baclofen infusion for severe spasticity in cerebral palsy. So we know that in children of cerebral palsy, there might be chronic contractures in the child. So whenever the contractures are present, the child is not able to move, you can use what is called as the intrathecal baclofen therapy. So I hope it is clear. So here we conclude, which is called as a neurosurgery module, and now we are going to head up to the new module, which is going to be head and neck anatomy and clinical examination. So these topics are predominantly covered in the ENT chapters, and they are very well covered in the senior faculty by who might be teaching ENT. They are also there in the typical ENT textbooks. But Bailey Love has given a short portion of these chapters, and mind you that these are asked in all the MRCS exams or internationally exams, irrespectively, even if you are not going to practice or you are not going to practice as a head and neck surgeon. So always remember that it might be asked somewhere or the other at some competitive exams. So it is very much important for you, and hence I am typically triggering this thing out, and so we'll just go through them. I might not teach every small part of it, just we are going to revise it. So just revise it along with me, and then we'll end up the session. So so basically we know that whenever the anterior parts, this is the nasal cavity and this is the oral cavity. So the posterior most part of the oral cavity is going to be, yes, the pillar of the tonsil. So whenever the anterior pillar of the tonsil is going to come, the 2/3 and 1/3 junction of the tongue is going to come. That is going to be the end of the oral cavity. So here we know that the oral cavity is ending, and here the pharynx is going to start. So behind the nasal cavity is going to be the nasopharynx, behind the oral cavity is the oropharynx, and behind the larynx is going to be the hypo or the laryngopharynx. So these are the three components. So that's what we are going to see. The nasopharynx is going to be from the skull base to the level of C1 to the soft palate. So from the skull base to the soft palate is your nasopharynx, and here what is clinically important is there is going to be fossa of Rosenmuller, and fossa of Rosenmuller is very much important because here behind actually the eustachian tube opening, there is going to be fossa of Rosenmuller, and from that fossa of Rosenmuller there is going to be an origination of what is called as a, yes, it is going to be causing nasopharyngeal carcinoma. So nasopharyngeal carcinoma is going to be here. So always remember, whenever in child there is going to be a serous otitis media, you are going to suspect what is called as, you are going to suspect adenoids. So whenever a SOM is seen, a serous otitis media is seen in child, you are going to suspect adenoids. But in adults, whenever a serous otitis media is there, you are going to suspect nasopharyngeal carcinoma. So you are going to suspect a nasopharyngeal carcinoma unless otherwise proved. So adenoid hypertrophy, it can lead to serous otitis media and sinusitis. But always remember that whenever you are dealing with any conditions here, keep in mind about the nasopharyngeal carcinoma. Oropharynx. So what is oropharynx? It extends from soft palate to the epiglottis. And what does it contain? It contains the palatine tonsils, the tongue base, and posterior pharyngeal wall. Always remember that for tonsils, few important conditions like Quinsy and oropharyngeal squamous cell carcinoma is very much important. So whenever there is NPC is related to Epstein-Barr virus. So Epstein-Barr virus is always related with nasopharyngeal cancer. And whenever you are talking about Quinsy, it is mostly related, whenever you are talking about oropharyngeal cancer, it is related to HPV. So it is related to HPV. And here there are some spaces which are parapharyngeal space and what is called as a retropharyngeal space. From where we are going to access these spaces, it is from the oral cavity, from the oropharynx. We are going to shortly talk about these spaces. What is hypopharynx? It is after the oropharynx. So when the base of the tongue is ending from the epiglottis to the lower border of cricoid. And what is important here? Here there are going to be the pyriform fossa in the bilateral region, in the postcricoid region. And always remember that these pyriform fossa are going to harbor what is called as a postcricoid cancer. So we are going to talk about one important phenomena is called as CUP. What is CUP? It is not the cup of tea. It is called as carcinoma of unknown primary. So many times you are going to see the neck nodes, and whenever you are going to do a biopsy of the neck neck nodes, they are going to be positive for SCC, squamous cell cancer. But all the regions, the nasopharynx, the oropharynx, the laryngopharynx might be normal, or patient's tonsils might be normal, the buccal cavity might be normal. So everything is normal, but patient has squamous cell carcinoma deposits in the lymph node. So from where do these lymph nodes can come? So most common site of these might be the NPC, the nasopharyngeal cancer, which might be missed on clinical examination. Another thing is an tonsillar cancer which can be missed, or another thing is a cancer in the postcricoid region from the fossa of, from your piriform fossa, which might be missed. So these are very much important things for you to know when we are dealing with what is called as carcinoma of unknown primary. So CUP is going to come to a surgery OPD, and how to evaluate a CUP we are going to see while we are going to conclude this chapter. So there are two spaces very much important, at least for surgeon's perspective. There are a lot of spaces: prevertebral space, the danger space, the alar space, parapharyngeal space, retropharyngeal space. But two main spaces which are important for your undergraduate level and as well as for your NEET PG are the parapharyngeal spaces or the retropharyngeal spaces. So what is a parapharyngeal space? So remember that whenever the oral cavity is ending laterally, which you can see between that and your mandible region, so this region typically comprises of your parapharyngeal space. So here you can see that this is going to be your whole oral cavity, and just lateral to that is called as what is called as a parapharyngeal space. And parapharyngeal space can harbor an abscess, and that abscess can actually push the tonsil medially. So many times what you can see as a tonsillitis, it might be something, an abscess related to the parapharyngeal space, and it might be a parapharyngeal abscess. So whenever you are dealing with tonsil, make sure that the parapharyngeal space, palpate that parapharyngeal space just from here. You can feel the fullness in the region if there is going to be some parapharyngeal abscess to the patient. So parapharyngeal space, it is an inverted pyramid like shape from skull base to the hyoid bone. And always remember that this parapharyngeal space is divided into pre-styloid and post-styloid region. So this is the styloid process which is going to be acting. So what is there in before that styloid process is the pre-styloid region. So it harbors what is called predominantly as a parotid gland. And whenever you are going to enter the post-styloid region, you encounter internal jugular vein, internal carotid artery, the sympathetic trunk, and the 10, 9, 10, and 11 cranial nerves. So any abscess or mass in this region is going to give rise to carotid encasement, IJV encasement, or these nerve getting trapped into the lesion. So it is very much important to deal with this. So this is the parapharyngeal space. What are the other spaces? So yes, just beneath the muscle and the alar fascia. So this is the vertebra. Covering the vertebra is going to be the prevertebral fascia. Covering the prevertebral fascia is going to be the alar fascia. So between the alar fascia and the muscles, if the abscess is going to develop, so this space predominantly is going to be called as a retropharyngeal abscess. But mind you that you can see here that what you can see, yes, you can see that there is going to be a midline raphe. So this midline raphe is going to restrict the retropharyngeal abscess to just one side. So a retropharyngeal abscess, when seen from the torch in the oral cavity, you can see that the abscess is lying just to the paramedian region. It is not covering the entire retropharynx. Just to the one side you are going to see this retropharyngeal abscess. But when you are going to see that abscess just behind that retropharyngeal space in the prealar space, that is also called as a danger space. Why is it called as a danger space? Because it communicates straight away to the mediastinum. So any abscess, if left untreated, it can go down to the mediastinum. So but this abscess is always going to be uniform. So you can see a bulge in the whole region, unlike the parapharyngeal abscess, which is going to be just to the paramedian region or one side of the midline. So remember, so retropharyngeal space between the constrictor muscles and the prevertebral fascia, so there contains the retropharyngeal nodes. And always remember that these are very much important while dealing with the children who are less than 4 years. So this abscess is, always remember, your retropharyngeal abscess, in cases of chronic abscess, never drain it from the mouth. Two reasons. A chronic retropharyngeal abscess might be a source of TB, and if you are going to drain it from the mouth, it can cause an oral fistula, and the child might actually go for what is called as, yes, it can go for aspiration, and it can cause sudden death of the child. So always remember, when treating electively, you have to take an approach through the lateral incisions. You have to go from the lateral neck. Whenever you are approaching this retropharyngeal space, whenever you are doing it in an elective setting for chronic abscess, so whenever you are going for elective settings in chronic abscess, when you are approaching this space, always you have to go from the lateral aspect of the neck. Never you are going to go from the oral cavity. Sir, oral cavity mein kab se drain karu? So whenever the child is going to be in acute condition, so if you are not going to drain, the child is going to die because of sepsis. So in acute conditions, you are going to drain with the help of oral cavity access. So that is very much important. Sir, how is larynx? So let's see the larynx. So we know that larynx is formed by 3 paired and 3 unpaired cartilages. So these cartilages are going to form the larynx. And what are the important parts of the larynx? So yes, the first important cartilage which we should know is cricoid, because we as surgeons are going to perform tracheostomies. And always remember that the narrowest portion of the larynx is going to be the vocal cords and the postcricoid region. So just behind the vocal cords, so just beneath the vocal cords, these are the vocal cords. So this is the narrowest portion, and just beneath them the region which is called as the postcricoid region. So postcricoid region is going to be the narrowest portion, and if you are going to do a tracheostomy at higher level, the permanent larynx can go into stenosis. So cricoid cartilage is the only complete cartilage, and it is the narrowest portion of the larynx, and chronic intubation, it can lead to subglottic stenosis. So very much important for us. Sir, what is posterior cricoarytenoid? So remember that the larynx, the muscles of the larynx are divided into 2 components. So if you can recall the anatomy, it is intrinsic and extrinsic. The intrinsic muscles are the muscles which are present inside the laryngeal cavity, and extrinsic, the only extrinsic muscle or the external appearing muscle is going to be, yes, it is the cricothyroid. And it is the only muscle which is going to be the extensor of the vocal cord. It is the only muscle which is going to be supplied by the superior laryngeal nerve. Rest all the muscles are supplied from recurrent laryngeal nerve. So the only nerve which is going to be supply the cricothyroid is going to be the superior laryngeal nerve, and it is the most common nerve which is going to be, the most common nerve which is going to be damaged during a thyroid surgery. So let's go and let's see. So what you can see here is, yes, you can see all the muscles. So what are the muscles? Yes, it is a thyroarytenoid muscle. So it is going from the arytenoid cartilage. So these are the arytenoid cartilage to the thyroid cartilage, and this is going to form what is called as a true vocal cord. So this is going to form the true vocal cord. Then there are, between the arytenoids, there are the transverse arytenoid muscles, and posterior cricoarytenoid muscle is the only adductor of the cord. So always remember that all the muscles are going to adduct the cord except the posterior cricoarytenoid muscle. So these are the muscles which you are going to see. So here you can see that these are oblique arytenoid muscles. These are called as posterior cricoarytenoid muscles. So we are going to see all the intrinsic muscles are adductors except the posterior cricoarytenoid. So all the intrinsic muscles of the laryngeal cavity are going to be adductors. So whenever there is going to be paralysis of the adductors, the vocal cord cannot come in between. So it is going to remain open like this. So whenever the vocal cord is going to remain open like this, it is going to cause breathy air, and that is the reason the patient's voice is not going to be articulated. You can see that the voice has got some airy tinge of the voice. So all the sensory, so remember, all the sensory component above this region. So above this region, all the sensory component is going to be supplied by superior laryngeal nerve, and all the sensory component below the vocal cord is going to be supplied by recurrent laryngeal nerve. So whenever you are going to have recurrent laryngeal nerve damage, it is also going to lead to infraglottic sensory nerve supply cut off. So below sensory, recurrent laryngeal nerve, and always remember that it is the sensory above the cords, it is because of the internal branch of the superior laryngeal nerve. So superior laryngeal nerve and inferior laryngeal nerve. So superior laryngeal nerve is going to divide into 2 components, internal and external. The external branch is going to supply the muscle, and internal branch is going to give the sensory supply. So that is how the laryngeal nerve is going to be divided. All motor components recurrent laryngeal nerve except cricothyroid. So recurrent laryngeal nerve palsy is going to lead to, a cadaveric position of the cord, because we know that posterior is the abductor and rest all are the adductors. So now no abduction, no adduction. So that is the reason the cord is going to stay in the cadaveric position. So not exactly open, not exactly closed, and that is the time when the patient is more prone for aspiration. So if unilateral damage is there, you can go for physiotherapy, but if bilateral recurrent nerve damage is going to be there, then that is the time you need to go for what is called as a permanent tracheostomy. So bilateral recurrent nerve damage, it is an airway emergency, and you need to go for a permanent tracheostomy to the patient. So very important for you to know. Motor cricoarytenoid. So what I told, that cricoarytenoid supplied by the external branch of superior laryngeal nerve, and always remember that it is important when you are going to talk in the high voice. So whenever you are going to operate a lady, when the husband is going to come to you that yes, that lady is very much talkative, she is very much angry on me, so you can straight away cut the superior laryngeal nerve. So just to make fun of you, don't take it seriously. But what my point of telling you is the high pitched voice is going to go for a toss, and rest all the functions are going to be normal. So any bathroom singer cannot sing anymore in bathroom because his high pitched voice is going to be cut. So always remember that when you are going to cut the superior laryngeal nerve, the extension component is going to go, and when the extension component is going to go, there is going to be problem with the high pitched voice. So very much important for you to know. Small MCQ point that there is a galenic communicating nerve. Most of the times what they have encountered is that even after cutting the recurrent laryngeal nerve, the supply is still intact. Why is that so? Because there is a small nerve which contains the which connects the superior laryngeal nerve to the recurrent laryngeal nerve, and it might confuse the nerve monitoring during thyroid surgery. But that is a rare anatomical variation, not seen in all of the patients, so you might not rectify it. But if it comes in exam, you should know what is it. So galenic communicating nerve. So whenever it is posterior cricoarytenoid only, it is the only abductor. Posterior cricoarytenoid is the only abductor. Rest all the muscles are adductors. And bilateral nerve palsy is an emergency threat because both the sides, abductors and adductors, are paralyzed, and hence the cord is going to go into what is called as a cadaveric position. So very much important to treat it like an emergency. So I hope it is clear. So now that is all about the basic anatomy of your larynx and pharynx. So now we are going to talk about the lymph nodes. So what are the lymph node stations? So this is what dissection was done, a radical neck dissection. So here you can see that this muscle is the mylohyoid muscle. This muscle is the mylohyoid muscle. Beyond that mylohyoid muscle is the lingual nerve. This is going to be the ramus of the mandible, and between the two carotids the hypoglossal nerve is going to pass. So if anybody is interested to see the actual anatomy, they can DM me. I can send them the actual resection video of the what you can say of the modified radical neck dissection. But this is how the neck is going to look when you are going to go for a radical neck dissection. So in simple terms, if you are going to see the lymph node levels, so remember that this is going to be the sternocleidomastoid muscle. The sternocleidomastoid muscle is going to divide the neck into anterior portion and the posterior portion. The anterior portion of the neck is further divided into different triangles based on the muscles. So this is going to be your digastric muscle. This digastric muscle is going to divide in what is called as 1A and 1B. The 1B is submandibular region, 1A is submental region. The 2, 3 and 4 level lymph nodes are divided on the hyoid bone and the cricoid bone. So this is going to divide the 2, 3 and 4 regions. And whenever in talking about the posteriorly, the omohyoid muscle, this omohyoid muscle is going to divide. Nowadays, previously the omohyoid used to divide into 5A and 5B, but nowadays what they use is they are going to use the cricoid cartilage as the landmark. So above it is 5A and below it is going to be the 5B. So this is how the neck nodes are in neck nodes revolve. Sir, why is it important to know? So always remember that whenever you are palpating a lymph node, so submandibular gland lymph node usually points down to something pathology related to the tongue or oral cavity. If there is a lymph node in the level 2, 3 and 4 region, it usually points down something to the pharynx or larynx lesion. So whenever you are not able to localize the lesion, so just based on the lymph node, you can actually retrospect the lesion. So why lymph nodes? So based on the lymph nodes, you can check which anatomical region is having pathology, and also vice versa. So whenever you are operating for oropharynx, you need not touch level 1A and 1B. Because the oropharynx is going to drain predominantly level 2, level 3 and level 4 group of lymph nodes. So you can just go for a selective neck dissection of 2, 3 and 4 region. So why is it important for you to know the lymph nodes? Sir, straight away सभी निकाल देंगे तो वो सब निकालने का नहीं रहता है, इसीलिए lymph nodes are going to be very much valuable. So again, 1A submental plus submandibular. What does it drain? So it drains from lips, floor of mouth, anterior tongue and cheek. So all the oral cavity into 1A and 1B group of lymph nodes. Level 2, upper jugulodigastric. All the pharyngeal spaces, the nasopharynx, oropharynx and hypopharynx are going to be drained into the level 2, 3 group of lymph nodes. So what is the level 3? It is the mid-jugular region. It again drains from the oral cavity, oropharynx, larynx and hypopharynx. And whenever it is level 4, lower jugular, larynx, hypopharynx, thyroid and esophagus. So whenever you are dealing with all the group of lymph nodes, you should know that from which area are these lymph nodes draining. Level 5 is posterior triangle from nasopharynx, oropharynx and scalp and posterior region. And level 6 is the central compartment, drains from thyroid, parathyroid, larynx, trachea and upper esophagus. So my point of telling you is that level 1A and 1B, take home points, 1A and 1B typically drain the oral cavity, 2, 3 and 4 from the pharynx region and also from the oral cavity, and posterior regions, some from the nasopharynx, some from the oropharynx and mainly from the scalp and posterior region. So this is the way of remembering the anatomical region and its lymph node drainage. So it is very much important. Sir, what are the types of neck dissections? So radical neck dissection was when we used to remove all the 5 group of lymph nodes. All the 5 group of lymph nodes. Along with that, we used to remove the sternocleidomastoid, internal jugular vein and spinal accessory nerve. But it caused a lot of morbidity. Even after preserving them, the outcome was going to be the same. So it was a historical procedure, now rarely done, and it has high shoulder dysfunction and cosmetic deformity. So nowadays what we follow is called as a MRND. So what is MRND? All the 5 levels lymph nodes are removed, but we can preserve either 1, 2 or all the 3 structures of SCM, spinal accessory nerve and yes, IJV. What is to be preserved? Based on that, they named that 1, 2 and 3. Nowadays that concept is obsolete. They used to say that 1 is when you are going to preserve the accessory nerve, 2 is when you are going to preserve the 2 structures, and 3 when you are going to preserve the 3 structures. Not important to know. Nowadays it is obsolete. So whenever you are going to go for an MRND, you can go for what is called as functional preservation. So if SCM is involved, remove only SCM. If spinal accessory is involved, only remove spinal accessory nerve. If only IJV is involved, only remove the IJV. So lymph node disease is positive for most of the head and neck malignancies. It preserves the function of shoulder dysfunction, which was a previous morbidity while dealing with the radical neck dissection. But nowadays, when we found out that the lymph nodes are draining into those particular region, so nowadays what they do is called as a functional neck dissection or selective neck dissection. So jitna involved hai utna hi nikalo, sab nikalne ke liye mat jao. So specific levels are only removed, typically in elective neck treatment based on primary site drainage. So it is very much important. I hope it is very much clear. So always remember some points while examining the head and neck region. So look from front and side, ask the patient to swallow. So asking the patient to swallow will determine the midline structures. Protrude the tongue for typically to look for any lingual relations. The flexion trick. So whenever you are not able to palpate properly, ask the patient to flex the neck and typically bend to the side you want to palpate. So if you want to palpate to the left side, ask the patient to flex the neck to the left side. So whenever the patient is going to flex the neck to the left side, naturally this region is going to relax. The sternocleidomastoid is going to relax and you can actually palpate, allow the deeper palpation of the nodes. So it is very much important for you to actually go for a flexion of the neck towards the side you want to palpate. Lift the tongue. So always examine the floor of the mouth. Never ever just go for palpating the lesion. Always examine the floor of the mouth. Modern fiber optic nasoendoscopes are passed through the nasal cavity without sedation, and here you can visualize the nasopharynx and larynx. So before concluding a CUP, what is called as a carcinoma unknown primary, that you are seeing a lymph node positive for malignancy, you cannot find out the primary. Before labeling it as a CUP, always go for a nasal and an oral endoscopy. That is called as a triple endoscopy: esophagoscopy, laryngoscopy and nasoendoscopy. So whenever you are going to do these 3 scopies, and these 3 are also going to be negative, and along with that there is not going to be any lesion in the MRI or CT scan, then you are going to label the patient as CUP, that is called as carcinoma of unknown primary. Rigid endoscope was previously used, but here it needs anesthesia for using a rigid endoscope. So I hope it is very much clear. Investigations in head and neck lesions. So what investigations do you use? The most common go-to investigation is going to be a CT neck, because most of the times you need to figure out the location, the extent, the lymph nodes. So CT neck is going to be an excellent diagnosis. It is going to also tell you about the level of lymph nodes, if there is any vascular invasion, if there is any bony involvement. All things are going to be clear on the CT. It is a primary investigation for bone involvement. But what is the problem here? It always requires contrast. Without contrast, you cannot do a CT HNF, because it will not tell you about the different structures. Sir, then what you can do for MRI. MRI is good for giving vascular soft tissue details. So it can also tell you about the perineural spread. We talked about perineural spread in malignancies. We told that any perineural spread has a worst prognosis. It can also tell you about the bone marrow involvement. So cortical involvement, C for C, cortical involvement told on a CT scan. But when you want to know a marrow involvement, the bone marrow involvement, then you have to go for an MRI. And why it is different? Because a cortical involvement of a mandible, if only cortex of the mandible is involved, you can go for what is called as a segmental resection, or you can go for a segmental resection. So this is the mandible, you can just remove the inferior segment of the mandible. But if the bone marrow is also involved, then you need to go for partial excision. You need to remove the whole segment. You cannot just go for a marginal excision. This is called as a marginal excision. Only one margin of the mandible is removed. But when the marrow is involved, whenever the bone marrow is involved, that is the time you should go for a segmental resection. So for bone marrow involvement, you need to go for MRI. PET scan, again useful for unknown primary, not used in routine investigations like head and neck cancers. So whenever you are suspecting a CUP, so you have done endoscopies, you have done a CT scan, but you cannot find out any lesion, only a lymph node is present with malignancy, that is the time you should go for a PET CT. It identifies primary in almost 40% of CUP cases. Lateral neck x-rays, again only and only x-rays are nowadays done to rule out the spine injury or any foreign body. So if air is present, post-cricoid, so post-endoscopic rupture or any foreign body in the esophagus, you can go for a lateral x-ray. It is simple and readily available. That is the only thing. FNAC, always remember FNAC for thyroid and lymph nodes. FNAC for thyroid and lymph nodes. We are going to talk in detail about how to do FNAC, what are the indications of FNAC in thyroid nodule when we are going to discuss thyroid. And always remember that FNAC is only going to tell you about the cells. It is not going to tell you about the tissue. So whenever you need to get a tissue, you need to do what is called as a core needle biopsy. So whenever the neck nodes are involved, predominantly if FNAC is inconclusive or you need a tissue biopsy. So why do you need a tissue biopsy when you should go for IHC? So what happens is whenever you are going to do a biopsy, whenever there is going to be SCC, nowadays this is a new protocol. So what is the new protocol? If you have seen SCC, no primary, and then you need to send this tissue for immunohistochemistry. What do? They go for staining for P16. Sir, P16 is a marker for Epstein-Barr virus. If it is Epstein-Barr virus positive, you are going to treat this as nasopharyngeal carcinoma. But if it is P16 negative, then you should think of oropharyngeal or laryngopharyngeal carcinoma. So that is very much important when you are dealing with malignancies of head and neck region, carcinoma unknown primary. So biopsy is typically needed if you want to go for immunohistochemistry. We are going to also talk about immunohistochemistry when we are going to talk about breast cancer. We are going to go for ERPR and HER2 status. So there again, IC is going to say and come and say hi to us. So it is very much important. So all the investigations of neck, that is what we told. A CT is important. Then an MRI is important, typically to rule out soft tissues and bone marrow involvement. PET scan is important. X-rays, minimal use but very simple use. Lateral x-rays, and then what is called as FNAC or core needle biopsy. We also discussed something about immunohistochemistry, which is very much important these days because immunohistochemistry is now guiding the treatment for further malignancies. So I hope it is very much clear. Now we are just going to complete a small condition which is called as infective conditions of the oropharynx and laryngopharynx, and then we'll stop for the day. So we will just take a couple of minutes break if you need, and then we are going to start again. So welcome back. So now we are going to talk about pharynx, tonsils, larynx and tracheostomy. So what do you mean by acute tonsillitis? So most commonly encountered condition in childhood, every one of us almost had a sore throat. So it is most commonly viral. So usually you don't need to do anything. So when you are going to do the examination of the cavity, you can see the swollen tonsils. If there is going to be some pus flakes on the tonsils, what we call as a folliculitis or the follicular swelling over the tonsil, it is most commonly something related to the bacterial, or else any of the tonsillitis is viral unless otherwise proved. You should go for a throat swab. In foreign countries, Epstein-Barr virus is most common. It is also called as a kissing disease. So whenever you are going to go for a throat swab, you can go for what is called as a monospot serology. So you can put that swab in the spot test and you can see if it is EBV positive. In India, we don't do it much, but it is given in the Western textbook because they follow the protocol. So what to do, sir, if it is EBV? So never give amoxiclav. What do you do? Any sore throat, write amoxiclav, send him home. No, because if it is an Epstein-Barr virus positive, it is going to cause infectious mononucleosis, and if you give amoxiclav typically in EBV settings, it is going to cause maculopapular rash all over the body, and patient will start developing fever which the patient did not have. So initially patient came to you only with sore throat and difficulty in swallowing. You saw the patient, अरे कोई नहीं उसको amoxiclav देके घर भेज, और amoxiclav देके घर भेजने के बाद से अचानक पेशेंट बोला दूसरे दिन आके सर फीवर आ रहा है. क्यों आ रहा है? क्योंकि तुमने उसको you gave him that maculopapular rash along with fever by giving him infectious mononucleosis like syndrome. And why is it going to happen? Because whenever you are going to give augmentin to this patient, whenever you are going to give amoxiclav to this patient, the patient is going to develop fever. So what is a Quinsy? So when we saw that peritonsillar space, so this is going to be the tonsil. So this is your tonsil, this is the oral cavity. This is the oral cavity, this is going to be the tonsil. So whenever there is an inflammation in the peritonsillar space, so typically when the inflammation is going to be there in this region, it is going to be called as quinsy. So quinsy is when there is going to be a medialization of the tonsil. You can see that tonsil is pouting out. The tonsil is pushed medially, and ipsilateral soft palate swelling is also seen. So typically what important point is that the ipsilateral palate swelling is also seen. And there might be trismus because the patient is not able to open the jaw properly. It is a clinical diagnosis, and whenever you are going to see, you can just go USG guided aspiration, or you can put a small nick over the anterior pillar and all the pus is going to come out. Sir, kitna pus bahar aayega? Hardly 1 ml, because that space is very small. Just let an incision and let the pus come out. It might not be a very it might not come like 10 ml 15 ml of pus bahar nahi aa sakta hai, but only after giving an incision, only a small amount of pus, only hardly 0.5 to 1 ml might come, but it is going to give a rapid symptomatic relief. So IV antibiotics and steroids. If it is a frank pus drainage, needle aspiration can be done. And between, always remember that where are you going to do an needle aspiration? So aspiration midway between the uvula and the upper molar tooth. So uvula and the upper molar tooth, between that midway you are going to go for an aspiration. And if the patient is having recurrent episodes, you can go for 6 weeks interval tonsillectomy. Sir, what if we do the tonsillectomy in the same settings? It is going to cause a lot of bleeding. It is called as hot tonsillectomy. So whenever you are going to do tonsillectomy in the settings of quinsy and active inflammation, it is going to be called as a hot tonsillectomy. Sir, we already saw parapharyngeal abscess. So it is posterior to the tonsillar pillar. So whenever the abscess cavity is going to lie outside this quinsy space, it is going to be a parapharyngeal abscess. We saw that parapharyngeal region is divided into two parts, pre-styloid and post-styloid region. So there might be a bulge over the posterior pillar, and also the bulge or fullness might be seen in the posterior submandibular region. So here you need to go for a CT neck, and surgical drainage is important. Avoid intraoral, because an intraoral might lead to aspiration. Always prefer an external incision or a cervical incision. So retropharyngeal abscess typically seen in young males, because in young males the retropharyngeal lymph nodes are very much reactive. Unlike adults, the retropharyngeal lymph nodes in children are very much reactive. And here what happens is, on a lateral neck X-ray, the wider you can see that the mediastinal space, the retropharyngeal space is widened, and actually the airway is a bit compromised. So CT neck can confirm it. And intraoral drainage if acute, and always remember chronic drainage if it is going to be a lateral drainage if it is going to be a chronic abscess, because if you are going to drain a chronic abscess intraorally, it can lead to what is called as a fistula, and always it is going to carry a risk of aspiration. So very much important for you to know. So what are the indications of tonsillectomy? So very much important for your ENT papers. Whenever there are going to be more than 5 to 7 episodes for 2 consecutive years, so more than 7 episodes or 5 episodes for 2 consecutive years, or more than 3 episodes per year for persistently 3 years, that is what is called as a Paradise criteria. So what do they say? What does Paradise say? Whenever it is going to be 5 episodes or 7 episodes per for 2 consecutive years, or more than 3 episodes for a year for 3 consecutive years. So एक साल में अगर उसको 5 बार tonsillitis हो रहा है, तो इसका मतलब it is very severe, you should go for a tonsillectomy. Another condition is a peritonsillar abscess. We saw that if recurrent quinsy is happening, recurrent peritonsillar epinos, second episode is the time when you should go for interval tonsillectomy. When the patient is having OSA related disorder, a small child is going to come to you with pulmonary hypertension. When you are going to check for the sleep study of the patient, you are going to see that tonsil is going to cause obstruction to the airway because of this chronic tonsillitis. The child is snoring and not able to breathe properly, and because of hypoxia at night and hypercapnia at night, the pulmonary vasoconstriction is going to happen, and that is the reason when you are going to go for a tonsillectomy in a small child. If you are suspecting a malignancy, so nowadays what they do in CUP, when you are not finding anything, you are going to also do a tonsillectomy. So what do they say? In CUP, there are a lot of protocols. All the oncological surgeons, head neck surgeons are going to tell you one thing. Onco surgeons are going to tell you one thing. ENTs are going to tell you one thing. So all the protocols are still under trial. There is no fixed protocol. But what do they say? That a cancer nowhere in the oral cavity with a lymph node in the neck, always think about a tonsillar abscess, and always think about a tonsillar malignancy. And you can straight away go for a tonsillectomy along with modified radical neck dissection. So CUP बाद में आने वाला है. मैं बाद में आपको वो fire कर रहा हूँ वो चीज़, so that you will get very much compliant to it. Access, how do you go for? So always remember that whenever you need an access to the retropharyngeal region or a parapharyngeal space, so whenever you're operating on a styloid process, whenever you're operating on a carotid region, and you need to go from transoral route, then you can go for tonsillectomy. It is going to give you an access to the parapharyngeal region. So what are the nasopharyngeal conditions which are very much important? So adenoid hypertrophy. So we know that there are two types of Walde's rings. So these are the rings which are going to be there sitting as a gatekeeper for the region. So whenever you are going to breathe any bacteria, this is the place where the bacteria is going to be engulfed and captured and is going to prevent from causing any further infections. So the inner ring is comprised of adenoids, tubal tonsils, palatine tonsils and lingual tonsils. Similarly, the external ring is formed by the neck nodes. Posteriorly, they are formed by retropharyngeal nodes, and anteriorly, these are formed by the cervical lymph nodes. So these Walde's rings are going to be present. So what happens is Walde's rings hypertrophy might lead in childhood and it usually regresses by puberty. So mother is going to come to you that the patient has recurrent tonsillitis episodes, recurrent adenoid episodes. So unless it is going to hamper any of the child's normal day-to-day activity, a child is going to have to take a lot of leaves from school. A child might have the problem with difficulty with breathing, pulmonary hypertension. The face is going to change. That is called as adenoid facies. Unless the child is having any secondary complications, you are not going to go for any type of surgery. It is going to regress by the time of puberty. It causes nasal obstruction, mouth breathing or snoring OSA and recurrent otitis media. It is going to cause eustachian tube dysfunction and cause recurrent otitis media. So what is an indication for doing the surgery? So the indication for doing surgery is going to be nasal obstruction or obstructive sleep apnea, recurrent otitis media because of which the hearing is getting hampered, or recurrent sinusitis or recurrent postnasal discharge. So that is the reason only when you are going to go for an adenoidectomy. Sir, something tell 4 lines about juvenile nasopharyngeal angiofibroma. So this is typically condition which is typically seen in young juveniles. So what do you mean by that? It is typically seen in young males. So a child who is going pre-pubertal or post-pubertal male child, he is going to see predominantly because it is influenced by testosterone. So it is a benign and highly vascular tumor, and exclusively in adolescent males, it is having testosterone dependent growth. So if you can see this in the nasal cavity, this is the tumor which is protruding. It is not a malignancy. It is just something related to the blood vessels. So why is it happening? So it is seen because of testosterone induced, you can see testosterone induced vasodilatation and vasoproliferation. It is common in northern India and Southeast Asia. Diagnosis is usually clinical and do not go for a biopsy. In Josh, you might say that अरे ओपीडी में आया है बच्चा, चलो चलो इधर के इधर ही टुकड़ा निकाल देते हैं. टुकड़ा निकालते निकालते बेबी का जान चला जाएगा. So never go for any biopsy during this time. And management is pre-operative embolization. Always remember, any vascular tumor in any part of the body, first you are going to go for angioembolization. It is going to shrink the tumor and then you can go for surgery. So what do? You are going to go for embolization through the maxillary artery because it is supplied by the maxillary artery. Then you are going to go for an open surgery or ionotomy approach, or an endoscopic resection can be done in smaller tumors. So direct निकालने का नहीं, उसको पहले embolize करने का, and then you are going to go for excision. So what is nasopharyngeal carcinoma? It is seen 30 times more in Chinese population. We talked about EBV association. Sir, कौन सा marker है? P16 marker is there for EBV. It is also elevated in Southeast Asia. It is typically a non-keratinizing and undifferentiated squamous cell carcinoma. So WHO is going to tell the squamous cell cancers into 1, 2 and 3. 1 is good differentiation, 2 is moderate differentiation, and 3 is going to be poorly differentiated. We have already talked about it when we were discussing about the squamous cell cancer, the skin cancers module in the plastic surgery. Usually diagnosed at advanced ages, and only 1/3 are going to be presenting with nasal symptoms. Most patients don't present with any symptoms. What are the nasal symptoms? They are going to develop serous otitis media. Most of the patients are not going to have any symptoms, but when they are going to present with symptoms, it is already going to be an advanced lesion. And whenever you are going to have a unilateral serous otitis media or cervical lymphadenopathy or a cranial nerve palsy, think about nasopharyngeal malignancy. Very much important. If primary is not found in carcinoma unknown primary, so again new protocol, you can go for a Fossa of Rosenmuller biopsy. What did we not see? We saw triple endoscopy, we saw PET scan, we saw what do we call as an immunohistochemistry, we saw tonsillar biopsy, now we are seeing Fossa of Rosenmuller biopsy. So कुछ भी कर सकते हैं, but primary को ढूंढ के ही निकालेंगे. So that is the approach what these people are having. Investigation is again MRI or PET scan. Management is going to be non-surgical because we are going to diagnose the tumor in very late stages, almost late stages, and nasopharynx is very difficult for going a radical surgery. So first, no cause, no harm. That's what we saw in surgical ethics. Non-maleficence, first do no harm to the patient. So you are going to go for, in stage 1 and stage 2 disease, you can go for intensity modulated radiation therapy. So we saw that focused radiation in the neck and surrounding region. But when the tumor is well blown, already cervical lymph nodes are affected, then you can go for cisplatin based chemoradiation. So why cisplatin used in radiation? So cisplatin acts as a radiosensitizer. So cisplatin is going to act as a radiosensitizer, and that is the reason when cisplatin is given, the cells are going to uptake good radiation. So what is one more important thing which you have to take care? So while doing radiation, we should take care that the patient is not anemic, because we saw that proper oxygen delivery is very much important. Anemia correction is very much important when you are dealing with nasopharyngeal cancer. Excellent. So surgery reserved only for highly specific recurrences. MRND can be done. 5-year survival rate is good overall if it is a stage 1 lesion, but if the stage goes on increasing, the patient's mortality is going to go on increasing. So what is an antrochoanal polyp? So whenever the polyps are going to be developing from the maxillary sinus, it is called as an antrochoanal polyp. So it is not vascular, it is going to be a pale lesion. JNA is going to be highly vascular, red and pink color lesion, and location to JNA, but it is same location as juvenile nasopharyngeal angiofibroma, but it is benign. And always you are going to go for an endoscopic excision. Here you don't need to go give a embolization. Embolization इधर देने का जरूरत नहीं है. So that's what is very much important when you are studying these diseases. Now tomorrow we will go for what is called as oropharynx and laryngeal cancers, and then last chapter which is going to be our cleft lip and cleft palate. Then we can conclude the topic tomorrow. So I hope you have got all the things together. If you have any doubts, you can ping me on WhatsApp. If anybody requires any video of specific neck dissection, you can just ping me up on WhatsApp. I'll be more than happy to share it to you. So I hope everything are clear. Till then, take care, bye bye and good night. See you tomorrow.